there's a lot in here.
Mm-hmm.
Hello? Oh,
What do you want?
is that beeping me?
It might be feedback. Is it feedbacking? Oh, that's weird.
Should I?
Is it because you're in the same room?
Yeah, how do we shut this off?
Which
one
was
was
beeping?
It was this. Hello, test. I'll shut that off. Okay.
I think this is a good spot for my coat.
Wait, what is that? What is this trifle poster that you have here?
I don't know what this is.
Wait, what is this? Is this like a bulletin board?
Do you want it?
What is that? Oh, it's a painting. It's like trees. Hold on, wait. I don't hear you.
Can you hear me now?
Mhm.
Okay.
Perfect.
Hi, we're just gonna wait another couple of minutes to let any stragglers make their way in. We're going to wait just another couple of minutes just to let anyone else join. Okay, we're going to get started. Hi, my name is Dina Rucco. I'm a PGY1 pharmacy resident at Stony Brook University Hospital. And the CE today is going to be on anticoagulation reversal agents. Just before we start, I have nothing to disclose, no financial interests or conflict of interest, just to get that out of the way. So our objectives for today are going to be to recall the classes of anticoagulants based on their mechanism of action, also to select the appropriate medication based on the guidelines and patient-specific factors, identify monitoring parameters for each class of anticoagulant, recognize the medications with reversal agents and review their mechanism of action, and then identify when the use of a reversal agent is indicated. Okay, so we're going to start with the coagulation cascade. So just a quick review. The coagulation cascade is our body's own way of forming a clot. So we have our own factors that are made in the liver that activate this. And then the big thing is we form prothrombin, and then through the use of factor 10A, that gets converted to thrombin. And then thrombin itself helps convert fibrinogen to fibrin, and that's what ultimately leads to the clot. In green, we have our common anticoagulants and where they work on the coagulation cascade. So we have our factor 10A inhibitors, including fondaparinux, rivaroxaban, apixaban, edoxaban, and betrixaban. We do have our heparins. For the sake of this CE, I am focusing on the oral anticoagulants, but they're just here for completion's sake. And then next we have our thrombin inhibitors. So we have bilvirudin, argatroban, and dabigatran. And then of course we have warfarin, which acts to deplete the factors that play a role in this cascade. And then to continue, so here I've added on the anticoagulation reversal agents and where they work. So we have Andexxa, which acts on factor 10A inhibitors, specifically rivaroxaban and apixaban. Then we have protamine that acts on heparin, again, just for completion's sake. And then we have idarucizumab, which is the inhibitor, or the reversal agent for dabigatran. And then we have vitamin K, which is the reversal agent for warfarin. I've also included PCC, which is a general non-specific reversal agent that we use that can act on the coagulation cascade itself, not on the drugs, but we'll get into that further on. So first, we're going to start off with warfarin. So warfarin is one of the older anticoagulants that we have. It works by inhibiting the vitamin K epoxide reductase complex, which causes a depletion in our own vitamin K, which reduces the vitamin K dependent factors. And those are factors 2, 7, 9, and 10. And it also affects protein C and S. So now I'm going to go into some of the reversal agents that we have. I'm going to start with more broad reversal agents, and then as I go on, we're going to get into the more specific reversal agents for the specific drugs. So first we have prothrombin complex concentrate. This literally just provides you back the coagulation factors that were depleted. So that we have 3 available in the US. We have 3-factor, 4-factor, and 4-factor A. And it's literally just the difference between which factors they're providing. 4-factor PCC or Kcentra is the common one that we see used for warfarin reversal because it is giving back the exact factors that warfarin is depleting by its mechanism. There are some considerations though when you're giving this. So it is weight-based dosing, which is something to keep in mind. And you also have to worry about hypersensitivity reactions. The prothrombin complex concentrate has a bunch of things besides just the factors. So it has albumin, it has some plasma protein. So things like this that patients can become hypersensitive to, it's just something to keep in mind. Then we also, when you're giving it specifically for warfarin, in terms of monitoring, you have to check the INR every 15 to 30 minutes after the dose. In addition to the albumin and the plasma protein that's in it, some formulations do also contain heparin. So this is something to keep in mind when you're going to give it to a patient who has a documented history of something like HIT, but not all formulations have it. And it is such a small amount of heparin in it, but it is also a consideration when deciding which type of reversal agent you're going to give. And studies show that when giving prothrombin complex concentrate, homeostasis is seen within 24 hours. Next up, which is another general reversal agent, we have fresh frozen plasma. So this is similar to PCC in that it gives back coagulation factors, but it also gives back other proteins and things that we find in whole blood. So the benefits of the fresh frozen plasma is that it's widely available and it has a lower cost compared to the PCCs. But the amount of fresh frozen plasma needed to correctly correct the INR may vary, and it depends on the individual patient themselves based on the relationship between the clotting factors and the coagulation test results. So it's kind of difficult to find the correct dose to give the patient. And then also the time to correct and the volume are both pretty large. So studies have shown that in order to correct INR, it may take over 30 hours for the fresh frozen plasma to do that. And the volume that is given is quite large. So this becomes a factor in determining if you're going to give it to it, because it depends on whether or not the patient themselves can handle that much volume that they'll be getting from the reversal agent. In addition, it has to be thawed, which may take a while to thaw out itself. So that is also a consideration when deciding what to give. Next, we have vitamin K. Vitamin K is more specific to warfarin, just mechanistically. So vitamin K is a fat-soluble vitamin that we normally get from our diet, and warfarin inhibits the vitamin K dependent factor, so it makes sense to give vitamin K to help the body make the factors that warfarin has depleted. But there are some considerations. So the big one is administration. There's a few different formulations that vitamin K comes in, but when you're giving it for warfarin-induced bleeding and for correction of the INR, you're going to see PO and IV formulations. PO is just there's nothing much to say about PO. We get vitamin K from our diet. Nothing crazy about that formulation. Sub-Q was originally made to try to get rid of the anaphylaxis that they saw related to giving vitamin K through IV push. But they saw that when they did give it for sub-Q for INR correction, there was an erratic absorption of the vitamin K. So it didn't correct the INR in a stable way. So due to these factors, they don't recommend giving sub-Q when you're trying to correct warfarin related bleeding and the INR. IM formulations, you run the risk of a hematoma. So that's why it's not given that way. And then IV, like I said, IV push, they saw anaphylaxis, but when you give it IV infusion, which is how it's given for warfarin reversal, the anaphylaxis risk is no longer there. Another consideration is that patients treated with high doses of vitamin K, and this is when you get over 5 milligrams, they can become resistant to warfarin up to 1 week. And this is because by giving the amount of vitamin K, it can build up in the liver, which causes it to bypass the VKOR enzyme that warfarin is binding to inhibit the factors. So the vitamin K itself can just bypass that whole thing, and that's how where the resistance comes from. INR correction can take anywhere between 24 and 72 hours when you're giving vitamin K. So next I have a little flow chart to see when it is correct, when it is guided to give the vitamin K or when to give the PCC and when to give the fresh frozen plasma. So the first thing you're looking at is if there's bleeding. So if there's no evidence of bleeding, then you're going to look at the INR. But as you can see, the boxes in green is when you're going to give vitamin K. So even if in all circumstances, regardless of there's bleeding or not, you're going to hold the warfarin itself. When it gets to INRs above 5 and even INRs above 10, you still don't have to give vitamin K. It comes down to the prescriber's discretion on whether or not they're going to actually give the vitamin K. So that's something to take note. Someone can come in with an INR above 10, but they might not require a reversal agent. So that's something just to keep in mind. If there is bleeding, though, they are going to receive some kind of reversal agent. There is minor bleeding or major bleeding. This is can become difficult to differentiate, and it is really a clinical decision based on the team. So major bleeding, for minor bleeding itself, you're going to hold the warfarin again, obviously, but then you're going to administer oral vitamin K at this point, 2.5 to 5 milligrams, and then you may have to repeat it within 24 hours. In terms of major bleeding, this is when you're going to be seeing the IV infusion of 10 milligrams and 50 mLs. And then in addition to this, you can either give the 4-factor PCC or the fresh frozen plasma. So the 4-factor PCC is usually if the bleed is life-threatening and continuing, and then the fresh frozen plasma comes down to whether or not the patient can tolerate the volume that you're going to be given. But yeah, this is just a little chart. Next, we have like a case question that we can run through. So ZE is a 70-year-old man who has been controlled on warfarin for over 5 years. He was recently treated with antibiotics for community-acquired pneumonia. He reports to the clinic for his routine warfarin monitoring, and his INR level comes back at 4.8 seconds. Choose the correct plan. You could either type it in the chat or we could just go over it. Give you a second to read the options. So the answer here is going to be B. Yes, Melinda got it. So B is the correct answer. You're just going to hold the next one to do doses. The patient isn't actively bleeding. So this comes down to INR. But again, like I said, the vitamin K isn't necessarily needed at this point. So next we have another case, a little more involved. Gigi is a 57-year-old female with AFib. She's been stable on warfarin for 3 years. Her cardiologist recently prescribed amiodarone without adjusting her other medications. And she was admitted to the ER with extreme weakness and vomiting blood. Her INR comes back at 9.8 seconds. Choose the correct plan for her. So I'll give you another minute to look over the options. So the answer here is actually D. You're going to hold the warfarin, yes, but because she has the extreme weakness and the vomiting blood, this is considered major bleeding. So you're going to be giving the IV vitamin K here. The option A is too low of a dose for her because she has the actual bleeding. But yeah. So to shift gears, now we're going to talk about the thrombin inhibitors, specifically dabigatran, because this is the oral one. And just to review, these are direct thrombin inhibitors, which prevent the conversion of fibrinogen to fibrin and ultimately prevents the formation of a clot. So the reversal agent for dabigatran is idarucizumab or Praxbind. So this one is indicated specifically for dabigatran-associated bleeding. It's a monoclonal antibody that binds to dabigatran with greater affinity than the dabigatran itself can bind to thrombin. So by doing this, it prevents it from acting in the coagulation cascade and helps to stop the bleeding. So in terms of dosing, the patient's gonna be getting 5 grams IV. And in terms of when to give it, it comes down to the dose that they're taking and whether or not, and the how, where their renal function's at. So if the dose was taken less than 12 hours ago and they have normal renal function, this is an indication to give the idarucizumab if they come in with a bleeding episode. If the dose was taken more than 12 hours ago, or the dose wasn't known, or they have renal insufficiency, at this point, you're going to be checking the thrombin time. And thrombin time is just a measure of the final step of coagulation, which is the conversion of fibrinogen to fibrin. So if the thrombin time is greater than 25 seconds, this is another indication to give idarucizumab. But if it's less than 25 seconds, a reversal agent is not needed at this point. So here's one of the studies that was done to help approve of idarucizumab. So it was a multi-center prospective single cohort study of about 503 patients, and it included two groups. So group A was patients who came in with an uncontrollable life-threatening bleed, and then group B were patients who were undergoing surgery or an invasive procedure that couldn't be delayed, and they needed to get to homeostasis before the procedure. The efficacy endpoint was the max percent of reversal of the anticoagulant of effects of dabigatran. And then they also looked at all of the, some of the coagulation tests. So they looked at diluted thrombin time, Ikarin clotting time, APTT, and the concentrations of unbound dabigatran, because idarucizumab works by binding to dabigatran itself. So it makes sense to study that. So this was the results of the study. On top, they looked at the diluted thrombin time. So if you see on the left-hand side, this is patients who were at baseline where they were at, and you can see it's anywhere between 40 to about 65 was the in seconds. But as you see, after they gave the idarucizumab, for up till 12 hours, even about 24 hours, they were below baseline, which shows the duration of action, shows that it does work, and it shows the duration of action is about 12 hours. And you can see somewhere between 12 to 24 hours is when you can start to see a peak. But even at 24 hours, it's nowhere near where they were at baseline. And then on the bottom in pink, it shows the concentration of unbound dabigatran. So this is really showing how well it binds to dabigatran itself. Again, you can see on the left-hand side, this is the baseline dabigatran concentration. Unbound dabigatran concentration, sorry. And then as you can see, after the dose of idarucizumab is given, it's at 0 for 12 hours, and somewhere between 12 and 24 hours is when it starts to peak. But again, it's nowhere near where we were at when we were in the beginning at baseline. So this is was a pretty promising study to show how well it works at acting on the coagulation tests and the duration of action. But there are some considerations. The monitoring itself is a consideration to keep in mind, because some of the DOACs that came out after warfarin, the whole draw to it was that you don't have to worry about all the monitoring that goes into warfarin. But in terms of when you give idarucizumab, that's when these coagulation tests become part of the therapy. The effects are seen within minutes, and then homeostasis is restored within 12 hours, which is a great time span. You do have to worry about hypersensitivity reactions. It is a monoclonal antibody, so we worry about that with all mAbs. But a big thing here is dabigatran is renally cleared itself, and idarucizumab has a short half-life. So you see the risk of patients with renal sufficiency where they could be given the idarucizumab to reverse the dabigatran-related bleed, but the idarucizumab could clear out faster than their own dabigatran is. So you run the risk of possibly having like an increased risk of bleeding after the dose of idarucizumab is out of the body. So monitoring patients with renal sufficiency is extremely important when considering idarucizumab. Next we'll move on to the factor Xa inhibitors. So again, these play on in the coagulation cascade and ultimately inhibit the formation of thrombin. Again, we're focusing on the ones in bold. Fondaparinux is a sub-Q factor Xa inhibitor, so we're not really focusing on that one. This is just a quick chart comparing the use of these oral anticoagulants. The big thing to take away here is that their renal dosing is required in all of them for different reasons, but dabigatran is the one that has the most renal clearance. It is about 80% renally cleared, so this is something to consider. And plays a role in when you're reversing the agents themselves. So the big reversal agent for factor 10A inhibitors is andexanet or Andexa. So this is the FDA-approved reversal agent specifically for apixaban and rivaroxaban. It's a modified inactive human factor 10A protein. And before this came out, the only available reversal agent for these drugs was PCC. And as these drugs have become more popular because of the draw of it oral being taken at home, and there's no need for routine coagulation testing, it was important for this drug to kind of come out because PCC was the only nonspecific reversal agent that we had. In terms of how it's dosed, there's 3 things to consider. So it depends on which anticoagulant they were on, the dose that they were on, and how long ago was their last dose before the bleeding episode happened. So regardless of drug, if it's been more than 8 hours, they're going to get low dose. And then whether they get high dose is going to depend on the dose and the medication. So rivaroxaban, the cutoff is 10 milligrams. So if they're taking less than 10 milligrams, they're going to get the low dose if it's been less than 8 hours. If they're taking more than 10 milligrams or the dose isn't known, they're going to get the high dose. If the dose isn't known, they're just going to assume it was a high dose just to cover themselves, and they're going to give the high dose. In terms of apixaban, the cutoff is 5 milligrams. So if they're taking less than 5 milligrams, they're going to get the low dose. And if they're taking more than 5 milligrams or the dose is not known, they're going to get the high dose. And when I say high dose and low dose, either one, you're going to both get the IV bolus and the IV infusion. And then the low dose is 400 milligrams at a rate of 30 milligrams per minute. And then the infusion itself is 4 milligrams per minute for 2 hours. And then the high dose is just double that. So 800 milligrams as the bolus over 30 milligrams per minute. And then the infusion is 8 milligrams per minute for 2 hours. It comes as either 100 milligram vials or 200 milligram vials. So as you can see, it can take a good 5 to 9 vials to make these doses if you're using the 200 milligram vials, and even more if you're using the 100 milligram vials. So this is something else that comes into play when determining if this is the right reversal agent. Here at Stony Brook, we actually have a power plant of a 1-bag system. So instead of creating the bolus and the infusion, we just put everything in 1 bag, and then we run it, and we're just able to change the rate of it as it's running. And when you give it, it does require a 0.2 to 0.22 micron inline polyether sulfone or equivalent low protein binding filter, because it is a factor 10A protein itself. So this was a study that came out that was used to basically approve this drug. It was a 2-part randomized placebo-controlled study, and there was 2 arms of the study. So one arm was patients who received apixaban, and one arm was patients who received rivaroxaban. And then within both arms, it was split between patients who received just bolus, and then the other patients received bolus plus infusion. The study itself included healthy older volunteers between 50 and 75 years old. The apixaban group was given 5 milligrams twice daily for about 3 days, and the rivaroxaban group was given 20 milligrams daily. So the primary endpoint of the study was to see the % change in anti-factor 10A activity. There was a total of 101 participants that were equally divided between both arms and between receiving the drug and receiving placebo. So the results of the study were pretty interesting. The black line with the circles is the placebo, and then the red line with the squares is the Andexa. So as you can see, on the top is the patients who received just bolus, and the bottom is the patients who received bolus plus infusion. So the patients who received bolus and in the patients who received infusion, you can see at the end of either the bolus or the infusion, there's about a 2-hour window before the Andexa group meets back up and even exceeds the placebo group in terms of anti-factor 10A activity. So this does show that when Andexa is being given, there is the anti-factor 10A activity is minimized, but as soon as the infusion or bolus is done, the anti-factor 10A activity starts to go back up to where it was. So this is something to consider. It only has about a 2-hour duration of action, and if let's say a patient's going in and comes in with a bleed and then has to go into surgery. If the surgery is going to last more than 2 hours, you run the risk of them having another bleeding episode. So this is something that was interesting because the manufacturer of Andexxa kind of denied that there was this bump up of the anti-factor Xa activity, and they do not recommend redosing. So this is also something to consider. So back to pricing. Pricing, like I said, it can require a good amount of vials to make just a single dose. So the low dose, you can see it costing around $33,000 for just the single dose, and the high dose can be up to just about $60,000 for the dose. So there are other considerations when giving this. So it depends, again, on these three things: the medication that they're giving, the strength of the medication, and the time of their last dose of anticoagulant. And it is only FDA approved for apixaban and rivaroxaban. That's not to say it cannot be used for the other ones, but it would be like an off-label indication. You also have to monitor for antibody development and infusion-related reactions. And again, the cost itself. So the manufacturer did come out with this Andexxa replacement credit program, and you can get credit. They have very specific ways you can get credit. So one of them is if the product was reconstituted for a labeled indication, meaning if it was for an apixaban or rivaroxaban induced bleed, and the patient expired before the administration, or the patient for some reason refused before administration, that's one way you can request a replacement credit. Or if the time period for administration after reconstitution has lapsed. So once you reconstitute it, it's only good for 8 hours. So if that time has passed for some reason, you can also apply for a replacement credit. But this application for the replacement has to be done within 30 days of the event. And every time an instance happens like this, you have to fill out the application itself. And the form itself is pretty extensive. And the manufacturer themselves does have the right to set certain limitations and conditions, and they do have the right to deny the credit to the drug. So even if everything that they're saying has to happen in order to get credit, they still have the right to say, no, we're not taking it back, you're not getting credit. So this was more to cover themselves because the cost of the drug was so expensive. They didn't want the reason a patient not to receive it be because of the cost. So this was a way to make sure that if a patient comes in, no one's withholding, reconstituting it, and making the bag just because of the cost. But like I said, before this came out, all we had to reverse these factor Xa inhibitors, related bleeding, was the 4-factor PCC. So this was a study that compared patients who came in with an intracranial bleed, and they compared patients who received the Andexxa versus patients who received the 4-factor PCC. There were 29 patients included, and the primary outcome was to see the percent of patients who achieved good or excellent hemostasis within 24 hours of the bleeding event. And then secondary outcomes, which I liked about the study, was to look at the incidence of thromboembolic events within 30 days. So what they found was that the effective homeostasis was achieved in about 89% of Andexxa patients and about 60% of the 4-factor PCC patients. But the bigger takeaway from this was the incidence of adverse events. So in terms of thrombosis, there was a 16.7% of patients had a thrombotic event in the Andexxa group, where only about 9% of patients had a thrombotic event if they received the 4-factor PCC. This study also looked at ICU admission, ICU length of stay, and overall hospital length of stay, which was all less in patients who received the PCC over the Andexxa. So this was something to show that because it kind of came out because of the fact that Andexxa was so expensive, this still shows that 4-factor PCC is a valuable and valid reversal agent that still can be used, because the homeostasis that was achieved was pretty comparable, and the incidence of adverse events was less in the 4-factor PCC group. There is a new agent that's currently in phase 2 trials, siraparantag. So this drug is claiming to be a universal agent that will be used to treat direct oral anticoagulants. So that includes the factor Xa inhibitors as well as dabigatran, and also low molecular weight heparin. And it's saying it binds to the drug itself, which prevents it from binding in the coagulation cascade and prevents and helps reestablish normal clot formation. It is administered IV over 10 minutes. So this is one of the studies that was done. There are ongoing studies. It is in phase 2. This was a double-blind, placebo-controlled trial involving 80 healthy individuals. And they were put into 8 different dosing cohorts, anywhere between 5 to 300 milligrams. So this study looked at the whole blood clotting time to measure the anticoagulant effects of edoxaban and the reversal. So all these patients received 60 milligrams of edoxaban, and then 3 hours later, they were given a varying dose, depending on which cohort they were in, to see how well it binds and acted on the edoxaban. So the results that they found, the patient in the beginning, that purple line going up is just everyone received the edoxaban 60 milligrams. After the PERT 977 was administered, you see a complete drop or a pretty significant drop in the green, blue, and orange groups, which were the 25, 100, and 300 milligram groups. And then the purple was the patients who received placebo. And this drop was constantly below the placebo group for about the whole time up until 27 hours, which was the length of time they monitored these patients. So this is pretty significant. The study showed that the hemostasis was restored within 10 to 30 minutes, and then it was sustained, this study said, for 24 hours, but you can see it even extended past the 24-hour mark. So this is a pretty promising study, and there are more studies in the works to see how well this drug works and where we can fit it in our therapy and guidelines. So when these patients are controlled at home on these DOACs, but they may have to come in for a scheduled procedure. And when this happens, they are going to have to stop their medication at some point before they come into the procedure to prevent the risk of bleeding. So when do we tell them to stop that? This is a little chart. It's going to depend on the medication that they're on, their patient's renal function, like I had before on that other chart. All of these DOACs are renally dosed. So, and it's also going to depend on the surgery bleeding risk, so what they're coming in for surgery or an invasive procedure, and their own bleeding risk. Now, obviously, we're not going to memorize a chart like this, so we actually have an app out there by iPro. It's called the Management of Anticoagulation in the Peri-Procedural Period, and it's a free app anyone can have, and it shows you can go onto it and put in all of the patient-specific factors. So what medication the patient was on, what dose they were on, their renal function, what procedure they're coming in for, and it will give you a recommendation on how long before the procedure the patient should stop the medication. So this is a very handy app that I think is pretty useful to have on your phone. But now in terms of when it comes down to an emergency or an acute bleed, when should a reversal agent actually be used? So the guidance from the Anticoagulation Forum states that in all patients who are receiving DOACs, the first line treatment is supportive measures before we go right to a reversal agent. And then the reversal agent is only indicated if the bleeding is life-threatening into a critical organ and the supportive measures have failed. This makes sense if we think back to the warfarin chart I had before. Not just because their INR was elevated, it didn't mean they were going to get the reversal agent. So that's something to keep in mind. Then the Anticoagulation Forum also stated that in terms of the dabigatran-associated bleeding and the rivaroxaban-associated bleeding and apixaban, the supportive measures are first, but then when a reversal agent is needed, you can give the idarucizumab for dabigatran, or you can give the Andexxa. They do recommend the Andexxa. But if either one of these is not available, they still suggest and encourage the use of the PCCs. So this is like based on the study and based on just we've studied it for so long. It's been around for a while. It still does work. So this is a pretty important note to have, that because not every hospital is going to have Andexxa on formulary specifically. So these patients will still be treated correctly and with a valid reversal agent. So I thought that was cool. So yeah, that's all I have. I'll leave this a little time for any questions anyone might have. So if there's no questions, what? Oh, I did have a question. Oh, that's just the factor 2 that the PCC just has factor 2. The APCC has factor 2A. It's just a different like form of a factor that we have. I don't know if that answered your question. Let me go back. Yeah, so it is still a 4-factor. It's just instead of like a 2, the 4-factor is 2, 7, 9, and 10, but the APCC is still 4-factor, but it's 2A, 7, 9, and 10. We just have like 2 different, it's just the different type of factor 2 that's going to be given. Okay. If there's no more questions, you will be receiving an email by the end of the day. Oh, sorry. Oh, there's one more question. I'm not too sure. When it comes to obese patients, yeah, I can look into that and I can definitely get back to you. I'm actually not too sure on which one we use when it comes to obese patients. But I will get back to you. Okay, no problem. So you guys will be receiving an email from me by the end of the day with the post-assessment questions and also the code for the CE. So make sure to log that in. Okay, thank you for tuning in.